So in this first discussion panel, what I would like to focus is about some specific aspects of the role and usage of bone marrow stem cell transplantation in patients with myelofibrosis, and also some evidence deriving from the literature, as well as the currently available guidelines for stem cell transplantation. These are my disclosures. Okay, so the first sentence is something that all of us know very well, but it's worthwhile to call it again every time, so that allogenic stem cell transplantation is the only curative option for myelofibrosis. And this will come quite clear from the next slides, but is something that we have to keep in mind when we deal with patients who are potential candidates for stem cell transplantation. We had a lot of new drugs, new achievements and new advances in the management of myelofibrosis, but the only curative option remains stem cell transplantation, with all its risk, potential of cure, but also risks for the patients. So I will try to touch in more specific way these 3 points: the current use of stem cell transplantation in myelofibrosis, how we could optimize transplant outcomes, and also just briefly touch a couple of special situations that are coming up to the attention of physicians, and particularly the colleagues that are involved in stem cell transplantation in patients with myelofibrosis, as well as other MPNs. So I think it's worthwhile to move from the NCCN guidelines for patients with myelofibrosis, those who are classified in the higher risk category, and we will go back to this statement in a couple of next slides. These patients are to be asked whether they are, and this is a question that the physician has to make as first question, is if the patient is a candidate or not for allogenic stem cell transplantation. If the answer is yes, if the patient is suitable, has a suitable donor, does not have too high risk variables in terms of other diseases and so on, and has a nice Karnofsky score, then the patient should be addressed to stem cell transplantation. If this is not the case, now a higher risk category patient with myelofibrosis might be handled in different ways according to his platelet counts, because the available options are different, in particularly in the United States, not yet approved in Europe. But pacritinib is a JAK inhibitor that has been approved for patients with thrombocytopenia. Otherwise, the patient could be also treated with momelotinib. In case of platelets greater than 50,000, we have other JAK inhibitors, in particular ruxolitinib, fedratinib, or momelotinib. Pacritinib might be used only special situation, and this is not actually the approval label. But in any case, these patients should be preferably considered for clinical trials. So there's definitely something that may appear as counterintuitive. So after the approval of ruxolitinib and more recently other JAK inhibitors, one might have started to think that the use of stem cell transplantation would decrease. And this is not actually the case. Indeed, there is a progressive increasing number of transplants that are performed for myelofibrosis in the last years. And these are the data that have been reported by the International Blood and Marrow Transplant Research Group. And so it's clear that there is a progressive increase in the use of stem cell transplantation for myelofibrosis. And this is one of the good sides of the use of ruxolitinib in clinical practice, because ruxolitinib is, and also other JAK inhibitors, through the experience is less than ruxolitinib, they represent a good bridge approach to facilitate the application of stem cell transplantation in patients with myelofibrosis. And another important aspect is that the age of patients with myelofibrosis who are actually transplanted in the last years is progressively increasing. So coming back to the second slide, what is a patient with higher risk disease? So clearly, when we face with a patient of myelofibrosis who has a potential transplanted age, the first question is, what is his risk category? Because the risk category is the key to decide whether or not the patient is a suitable candidate for stem cell transplantation. Here you can see that there has been a strong and renewed interest in the development of clinical first and more recently mixed clinical and molecular, and also examples of only mutation and karyotype-based clinical scores for assessing the risk of the patients. So according to the NCCN guidelines, the MIPS-70 or the MIPS-70 version 2 should be the preferred model used for risk stratifying a suitable stem cell transplant candidate patient. Otherwise, if these are not available, the dynamic IPSS model is recommended, or if karyotype is not available, the IPSS without, not plus, but the conventional one. And also the MySEC PM score is suggested to be used for patients with post-PV and post-ET myelofibrosis. And I would say quite smartly, the NCCN guidelines actually divide patients into main risk categories, the lower risk and the higher risk, that are made up by different options in those clinical scores. Of note, in the last version of the NCCN guidelines, the presence of anemia associated with myelofibrosis represent an individual category of patients in terms of risk. And see, this is something new that came up, of course, with the knowledge of this cytopenic variant of myelofibrosis. So the first step is assessing the indication for stem cell transplant in a patient. Second step is how great is the risk for that patient to be transplanted. And here we can take advantage of this MTSS model developed by Nicholas Kruger and colleagues, that by using the variables that are listed in the bottom of the slides, that are some patient-related variables, such as the Karnofsky score, the age, and the platelet count, some that are related to the donor, in particular the mismatch donor, and also other that are associated with the disease, such as leukocytosis, the absence of CAR or MPN mutation, and the presence of an ASXL1 mutation. And by using these variables, it's possible to divide patients in 4 risk categories. And it's quite clear that these categories are very different in terms of non-relapse mortality at 5 years and overall survival at 5 years. And this is something that can help the transplanter to decide about the suitability of a patient, but also are very useful in speaking with the patient and discussing about the expected role of transplantation beyond the indication of the patient. So on the basis of largely those data that we have seen in previous slides, the BMT and the European Leukemia Net delivered recommendations. There are 2 versions. The first one was in 2015, and the more recent one is just 2024. And here you can appreciate the indications, the recommendation for stem cell transplantation. So in case of patients who are less than 70, according to the 2015, and are IPSS or the IPSS plus intermediate to or high risk, that was an indication. More or less same statement in 2024, but with the addition of the molecular-based score, and also includes the transplant score, low or intermediate risk. For patients intermediate to and high risk, that means largely the higher NCCN risk category, the transplant is indicated if the MTSS is low or intermediate in all patients aged less than 70 years. In case of patients who are intermediate to 1 risk, and this is a borderline category in the NCCN guidelines between the lower and the intermediate risk, and are MTSS low, the transplant should be offered, but taking into account also a more broadly evaluation of the patients, and in particular also the preferences of the patient. And finally, some characteristics of the disease that are not yet included. Maybe they will be in the next future, but they are not yet been included in the scores, such as, for example, the presence of TP53 mutations. We'll go back to this in a while. For patients who are older than 70 years, here the decision is largely based on the preference of the patient, but especially on a careful evaluation of what is the risk associated with the procedure in terms of disease, transplant procedure, and patient characteristics. Third step, very difficult, is deciding about the optimal timing for transplantation in myelofibrosis. Here we have to say that we still need studies. We still need to have, for example, Markov models to understand in a more rigorous way what is the best time for a patient to undergo stem cell transplantation. In this slide, however, the experience that has been built up in the past years would suggest that while patients with intermediate and high risk should be transplanted quite shortly after the diagnosis, hopefully within 1 year, 1.5 years, the transplant may be delayed in patients who are intermediate to and are potential candidate for stem cell transplantation, while it probably should not be performed except in very rare cases in patients with low-risk disease. But here deciding about optimal timing is difficult. Now we have also another variable that comes into the play, and this is the treatment with the JAK inhibitors. Patients feel better. They often are willing to postpone as much as possible the transplant procedure, and this may not be the right choice in any case. I mentioned before special situations, and these are just an example of that. So the role of TP53 mutations in transplant. We know from several other diseases, including acute leukemia, myelodysplastic syndromes, and so on, that mutations in TP53 are associated with worse prognosis. And unfortunately, this remains also for patients who are subjected to stem cell transplantation. Here you can appreciate that the median survival of patients who are transplanted with a TP53 wild-type disease in this study is almost 14 years, as compared to less than 2 years for patients who are mutated for TP53. And in addition, we have started to appreciate that not all TP53 mutated patients are the same, because if the patient is single hit, the outcome may be not so much different from a wild-type patient, but if the patient is multi-hit, then the prognosis is definitely worse, remains worse also after stem cell transplantation. So this is a difficult category of patients to deal with in terms of decisions to undergo to stem cell transplantation if these are multi-hit mutated. And also another special situation is represented by patients in accelerate and blast phase. So according to the NCCN guidelines, if the patient is in accelerate phase, this patient maintains the candidability for stem cell transplantation, and these patients might be transplanted without any additional therapy directed to reduction of blast counts. On the other hand, a patient in blast phase is not by himself a candidate for stem cell transplantation, but hopefully he might be enrolled in clinical trials or may be treated in a conventional setting with, for example, venetoclax and azacitidine or decitabine, in order to reduce an accelerate phase, if not a chronic phase. And so this patient might be bridged anyway to stem cell transplantation. And what are the outcomes of these patients if you consider patient in accelerate phase, you can appreciate that the outcome is not far different from patients transplanted in chronic phase. The 5-year survival in this large analysis was 64% as compared to 65% for the patients transplanted in accelerate phase. Of course, the numbers are quite different, but if the patient is transplanted in blast phase, then additional variables should be clearly taken into account, such as the Karnofsky score, and particularly the status at the transplant. If a patient is reinduced in chronic phase, then the outcome is definitely better as compared to patients who are not transplanted in accelerate or chronic or reduced chronic phase. Lastly, the impact of splenomegaly. There are data that suggest that patients with a large spleen volumes have worse outcome after the procedure. And so this is a retrospective analysis of the EBMT on almost 1,200 patients with myelofibrosis, of which 200 underwent splenectomy. And as you can see, patients who underwent splenectomy have generally better outcome as compared to those who were transplanted with large spleen. And it was also shown that the spleen size maintained the prognostic significance on the outcome of stem cell transplantation, also in patients receiving ruxolitinib. And there is a progressive increase in the added value of survival depending on the spleen size, less than 5 or greater than 15 centimeters. And so this led to the development of a position paper of a BMT regarding the management of splenomegaly that in summary states that patients with spleen less than 5 centimeters, it suggests that any patient with a spleen greater than 5 centimeters should be treated with the JAK inhibitors, hopefully at the maximum tolerated dose for at least 3 months. Spleen less than 5 centimeters, go green light to stem cell transplantation. Spleen that is 5 to 14 centimeters, then you can go to stem cell transplantation with additional risk, but preferably consider an alternative JAK inhibitors or splenectomy in more common cases, splenic irradiation. If the spleen is greater than 15 centimeters, then before going to stem cell transplantation, you should anyway try an alternative JAK inhibitor or splenectomy or irradiation. So the message is try to not transplant a patient who has a spleen larger than 15 centimeters. And also how this is something that is an evolving field in the management of stem cell transplantation and myelofibrosis, how to deal with the relapse. So this is a very important issue because we know that up to 30–40% of patients may relapse after stem cell transplantation. And we also know that there is some evidence of a graft versus disease in special situations. And so it's very important to have a careful approach to monitor the relapse after stem cell transplantation. And so according to these recommendations, there are different levels of relapse, the molecular, the cytogenetics, both molecular and cytogenetics, and morphological and clinical relapse. And without going into the details of these different categories, the action should be in order to be very active, preventive to full relapse of the disease. So just to summarize, we touched some points regarding the new information and the new positions also of guidelines in terms of the use of stem cell transplantation, indications, how to deal with older patients, and even more how to appropriately use risk stratification systems according to the guidelines. We know that splenomegaly is something that might affect the outcome of stem cell transplantation, and now we are much more able as compared to the past in managing splenomegaly. and also special focus in monitoring post-transplant course. Finally, these are still largely unmet clinical needs, how to deal with TP53 mutated myelofibrosis and MPN in general for stem cell transplantation, and how to deal with patients who are in accelerate or blast phase. The last slide, next one, please. So these are the take-home message that we have discussed, and I will not spend further time on this, if not stressing again that this is a very early decision for a patient with myelofibrosis, that we have several tools now that should be applied in a very consistent way to our patient population.